Good evening, everyone. Welcome to the live webinar on COVID-19 and Diagnostic Radiology, organized by the College of Radiology Singapore, supported by the Academy of Medicine Singapore, as well as the Singapore Radiological Society. I'm Dr. Teh Kiang Hyong. I'm a radiologist with the Singapore General Hospital. I'm also currently the president of the college. Before we begin, let me go through some house rules. You probably would have seen the slides earlier. So if you can, please use a strong Wi-Fi for the better video quality. All participants will be muted so that there's no interruption to the speakers. We will be recording this webinar, so for those of you who miss it, we will post it onto our college website. For local doctors, if you attend the full 1.5 hour session, you will be accorded 1 CME point after the event. Is there a next slide? Yep. At the end of the presentation, there will be a question and answer. Throughout the webinar, you can actually send in your question through this Q&A button, which you can find it on the bottom of the taskbar of the Zoom application. We will answer the question at the end of the session. Okay, so tonight we are very honored and privileged to have 4 distinguished speakers, 2 locally, and we are very happy to have a speaker from Daegu, Korea. As you know, is quite badly hit by COVID-19. We also have a speaker from Hong Kong, and we all know that Hong Kong is one of the few countries that have managed to flatten the curve, so to speak, and we hope to learn from them. Without further ado, I will introduce the first speaker. She is Dr. Charlene Liu from Changi General Hospital. She's a senior consultant radiologist. She's also currently our chairman for the chapter of Diagnostic Radiology in the College of Radiologists. Tonight, she'll be speaking to us on imaging findings in COVID-19. Charlene, please.
Thank you very much, Prof. Thank you very much, Prof, for the invitation to speak tonight. Tonight, I'm going to actually show everyone the imaging findings of COVID-19. And I think for those of us who are participating locally, I think it's especially sombering to note, especially since right now we are seeing our epidemic curve increase in a almost vertical trajectory. So I think it's something that's very salient to all of us. So a few key messages that I would like to impart to you tonight is that viral pneumonias of all causes from any respiratory viral pathogen looks very similar on chest X-ray and CT. For example, the influenzas, the parainfluenzas, the adenoviruses, and the coronavirus. And this is actually well known amongst
Unmute. Charlene, sorry, can I stop you here? Can you share your slides? We can't see your slides yet.
Oh, I see. Okay.
Yeah.
I'll go back.
Yes, now we can see it.
Okay, sorry, I forgot to click the button. Okay, sorry about that. So a bit of a technical problem. So yes, I was just going through this curve to show that we are now currently facing a vertical upslope in our epidemic curve. So it's particularly sombering for us all to note here in Singapore. So a few key messages. The viral pneumonias of all causes look very similar on chest X-ray and CT. And the appearance of COVID-19 can be actually quite protean on CT. But there are some commonalities, and I would like to impart them to you. COVID-19 appears to follow the pattern of the coronavirus pneumonias. So for those of us who have actually encountered SARS and MERS before in our practice, it will actually be quite familiar to you. There is also a known occurrence of false negative chest X-ray. So this is very important to bear in mind. chest CT is also a useful ancillary tool in the early diagnosis of COVID-19 pneumonias. So when we train our radiologists, we always go through the radiological pathological correlation, what we call RAD-path. It's important to understand the pathogenesis of a disease before you can understand what it's going to look like on imaging. So clinically, viral pneumonias in adults can be divided into two groups, the so-called atypical pneumonias in otherwise healthy hosts, and the viral pneumonias in immunocompromised hosts. So the predominant pathological process in severe COVID-19 is what we call a diffuse alveolar damage. And it's actually characterized histologically by interstitial edema and central alveolar filling. So for those of you who have any experience in pathology, you will note that both of these slides actually show a very similar pathological process. And indeed, the top slide is from a patient with SARS, and the bottom slide is from a patient with COVID-19. And what you see here is actually what they call diffuse alveolar damage. So the air cells, the air sacs, are completely filled with sloughed off necrotized cells, as you can see. So on a chest X-ray, it's very important to note that it may actually look completely normal in the early phase. So that's very important to bear in mind, especially if you have a suspect case with very suggestive symptoms. Earlier on, you might find that the pattern of disease is unilateral, but quickly it becomes bilateral in appearance with patchy areas of confluence, consolidation, which may become very large and extend from the periphery all the way to the center. Also, a feature which you might note is the presence of bronchial wall thickening, like so, the red indicated by the red arrow. Patients may also develop acute respiratory distress syndrome, ARDS, which is shown on the next slide if they become severely ill. And in radiology, we always note not only the presence of pathology, but we also note the important absence of certain findings. So it's notable to see that there is an absence of nodal enlargement and also a complete absence of pleural effusions, which you would typically expect to see in a pneumonia of this kind of severity. And so here on the next slide, you can see a progression on chest X-ray, where the radiographic features are very, very similar, in fact, indistinguishable from acute respiratory distress syndrome. So this patient had very severe ARDS from SARS, and you can see that there are diffuse bilateral airspace consolidations and the presence of air bronchograms, what we call a white out of the lung. And as these patients are usually very ill and in ICU, they have the presence of endotracheal tubes in situ as they require ventilatory support. Okay, so now we shall move on to the CT appearance of COVID-19. So as mentioned earlier, if you find a very early phase patient, you may actually appreciate that the findings are unilateral, but these findings often become bilateral very quickly. And they tend to present initially in the early phase of infection with a ground glass opacity. And what we mean by ground glass is that you see a hazy opacity in the lung, which actually does not obscure the margins of the adjacent blood vessels or the bronchial wall markings. And so you can actually appreciate the preservation of the margins of these structures. And so this is what we call ground glass opacity. And what we've actually noticed anecdotally is in COVID-19 patients, these ground glass opacities, they tend to be quite well circumscribed. And this is in contradistinction to other causes of diffuse bilateral ground glass opacification, such as PCP infection and such as acute pulmonary edema. So this is actually a feature which is quite important to note. As the patient progresses in severity, we may find that the areas of ground glass opacification can become mixed in appearance and develop areas of consolidation. And we may also see the thickening of the interlobular septae or the intralobular interstitium. If marked septal thickening occurs, like so, we describe a feature which is called crazy paving. And I will actually elaborate on that further. And it's also important to note the conspicuous absence of pleural effusions, the absence of nodules, lymphadenopathy, and cavitation, in which case you should always think of a separate intercurrent illness or infection, such as with a bacterial pneumonia, or a completely different diagnosis. Okay, so now we'll take you through a series of images. So this is the same patient, as you can see. There are large confluent areas of ground glass opacification, some areas of interlobular septal thickening giving rise to a crazy paving appearance. There is no particular zone of predilection. And on the mediastinal window of the soft tissue setting, we note the conspicuous absence of pleural effusions. Okay, so this is a separate patient who had actually presented after flying in from Wuhan, and he developed symptoms approximately 7 days before this CT scan was performed. And so as you can see, this patient has actually developed a more severe manifestation of COVID-19, and the areas of ground glass opacification have started to become more mixed in appearance with areas of consolidation. Now note that you cannot make out the margins of the blood vessels or the bronchial walls, and so this is actually consolidation rather than ground glass changes. And you can see that the changes are bilateral, they are quite extensive. Again, there is no particular zonal predilection. And note the conspicuous absence of pleural effusions and the absence of enlarged lymph nodes. Okay, so just to recap, the CT imaging findings are usually bilateral and maybe unilateral in the very early phase. There is a predominance of ground glass findings with mixed ground glass and consolidation in the later phase of infection. The opacities tend to be confluent and patchy. They may be well circumscribed. They are mainly subpleural in location or peripheral. There is no apparent lobar predominance, no subpleural sparing, as is seen with several other differential diagnoses, such as organizing pneumonia and NSIP. There is a conspicuous absence of nodules, no cavities, no lymph node enlargement or pleural effusions. So Jeffrey Kanner summarized all these findings quite nicely in a table in a publication in Radiology, and he actually described the frequency of the different imaging findings. So ground glass opacity was the most common imaging appearance of 86%, followed by consolidation, some crazy paving. Linear opacities were also present, but the complete absence of cavitation, nodules, pleural effusions, and lymphadenopathy. The findings tended to be bilateral in distribution and in a peripheral distribution as well. So here's a slide which shows up close an image of crazy paving. So you can see markedly thickened in intralobular interstitium and interlobular septations, and on a background of ground glass opacification, which is circumscribed in this particular patient. So this is what we term as the crazy paving appearance. So in a separate publication by Pan, they describe the time course of lung changes on CT, which I find to be very helpful. The blue bars actually indicate the appearance of ground glass opacities, as you can see, tends to manifest early in the course of the disease and tapering off in the later phase of the disease after 14 days. A crazy paving pattern was also appreciated quite early on in the course of the disease, and consolidation, on the other hand, tended to appear only later in the time course of the disease and tapered off. So, as we have also noted, they describe that there is sometimes a mixed consolidative and ground glass appearance, and improvements seem to occur at a peak of 9 to 12 days. And this was found to correspond to a resolution of ground glass opacities, leaving parenchymal bands, which would be appreciated approximately 1 month later. So this was actually the first paper which described the progression of disease on imaging. This paper actually was published in during the SARS epidemic, and as they had the opportunity to study patients over a longer time period, and it showed that actually a significant proportion of patients progressed to ARDS, and as a result of intubation and mechanical ventilation, a significant proportion of their patients also developed evidence of barotrauma. So this is actually an important finding to note if you are looking after ICU patients. And so you can see here pockets of gas in the mediastinum. This is called pneumomediastinum, as well as a very diffuse appearance of ground glass appearance and consolidation in both lungs in keeping with ARDS. So this patient has developed complications from intubation and ventilation. In a later phase, this is in the chronic follow-up period, many of these patients actually were found to develop evidence of fibrosis, as you can see here in the basal areas of the lungs. This is actually what we call traction bronchiectasis, where the airways are actually being pulled apart by adjacent scarring. So this is a very typical feature of interstitial fibrosis. So there have been some controversies which have been addressed in multiple discussions regarding the diagnosis of COVID-19. I won't go into very much detail, but I will highlight that there are advantages to different approaches, and especially to note in a different set of circumstances. So the reference standard is still currently a diagnosis with reverse transcriptase PCR, and it is the WHO definition of a confirmed case. Currently, there are sufficient PCR kits in Singapore, but the typical turnaround time is approximately 24 hours. There is a known occurrence of false negatives, which has been thought to be due to sampling errors, immaturity of the test kit technology, and the fact that the viral shedding appears to peak a few days after symptom onset, which may be not in sync with the time of the sampling. Furthermore, for CT, we have several advantages using imaging to detect very early pneumonia in the setting of negative PCR, which has been found to be the case up to 22% of the time, and a reported higher sensitivity compared to RT-PCR of 98% versus 66 to 71% for PCR. There is an argument that CT does expose the patient to ionizing radiation of approximately 5 millisieverts, which translates to 1 in 4,000 lifetime risk of fatal cancer. However, as clinicians, as radiologists, we balance risk and benefit, and we note that the case fatality rate of COVID-19 infection is approximately 2.4%. Thus, the risk of demise from COVID is actually poses a higher risk compared to ionizing radiation. However, there are very significant challenges for infection control, terminal cleaning, which is required for CT scanners after a patient is scanned, which takes up to 3 hours. And the fact that CT imaging can be very non-specific, as we've touched upon earlier. There are imaging mimics, which include other viral pneumonias, and organizing pneumonias, as well as eosinophilic pneumonias. So in summary, if I can just highlight several of the imaging pearls of CT features of COVID-19, we'd like to divide imaging findings into two groups, early and severe. In the early group, we see patchy ground glass opacities, which are mainly subpleural or peripheral, and occasionally we see crazy paving. In a severe phase of infection, it is often indistinguishable from ARDS on CT, and ARDS in turn is associated with many complications, including barotrauma, pneumomediastinum, and late fibrosis. Okay, so my time is almost up. I'll just quickly show you some of the future applications of imaging in combating COVID-19. And in several centers in Singapore, we have actually been working on developing deep learning technologies to either diagnose or prognosticate the cause of infection for COVID-19. These are just some of the slides we have borrowed courtesy of our colleagues at IHIS and at Changi General Hospital. And so in summary, we are still learning about the imaging findings of COVID-19. It correlates to epidemiological presentation and the temporal progression of imaging findings. We are still very much on a learning curve. Chest X-ray may be normal in early phases of infections. The CT is a useful adjunct tool in two situations: in a COVID-19 positive patient who is suspected of having complications, and when we have a suspect for COVID-19 with negative swabs and a normal chest X-ray, but with deteriorating clinical features such as oxygen saturation, to exclude other important differential diagnoses, for example, pulmonary embolism, and to assess the underlying lung parenchyma. Strongly suggestive CT findings should always prompt the clinician to repeat COVID-19 sampling. So future applications include CT-based severity scoring, long-term follow-up of sequelae in survivors, and imaging-based multimodal AI analysis for predictive modeling. And with that, I conclude my webinar, and thank you very much for your attention.
Thanks, Charlene, for the very comprehensive review of the imaging findings for COVID-19. For those of you who just joined us, just to remind that there is possibility for asking questions in this webinar. There will be a Q&A at the end. In the meantime, you can click on the Q&A button at the bottom of the Zoom application, and we will address your questions at the end of the seminar. So next, I would like to introduce the next speaker. He is Dr. Lionel Cheng, Senior Consultant Radiologist at the Singapore General Hospital. He'll be speaking to us on the operational considerations for radiology department in COVID-19. So Lionel has recently published in AJR on this topic, so he's no better person to speak to us. Lionel, please.
Thanks, Kang Hyung. So we're going to switch tack a little bit to talk about operational considerations for a radiology department during the COVID-19 pandemic. So some disclaimers. These are my personal perspectives, and we have to acknowledge that every hospital situation is unique. So there is no one-size-fits-all solution or template, and we're just sharing our experience at this point in time. So Charlene has already talked about the curve that we're seeing in Singapore. What I wanted to highlight is that prior to the first case that we saw in Singapore on January 23rd, our hospital had already begun some preparation. And even within the radiology division, our division of radiological sciences, the initial setup of the outbreak task force had already started. We subsequently switched our national alertness level to up one level on 7th of February, and we had our first mortalities on 21st March. So we're currently into week 11 since our first case, and probably longer than that since we started preparing. So Kang Hyung has nicely mentioned that we published our experience with SARS and how it influenced our response to the COVID-19 epidemic in AJR. It was e-published on 5th March, though it feels like a lifetime ago. Those who are interested can check it out at the Röntgen Ray Society website or the College of Radiology website. But what I wanted to highlight was one table which we put in this publication, which talked about operational considerations. And this table listed several areas for review and asked different questions that we felt were important to consider in planning a response. So I'll now run through some of the areas that we covered in that paper. The 3 domains that we looked at were firstly people, the second was places and equipment, and finally processes and policies. And I'll now go into a little bit more detail into each of these domains. So starting with people, I mean, they're the most important aspect of any pandemic response. So the first thing that struck us was that we had to leverage on all existing platforms to rapidly share information. So we used Workplace by Facebook and Tiger Connect for the HIPAA-compliant messaging services. WhatsApp was also used, but for non-sensitive data. It was a challenge to actually make sure that every single person gets the message. Most of us would think that every department knows who's in the department, but when push comes to shove in a difficult situation and when you rapidly need to get information across, it is not that easy to make sure every last person gets the message, right down to the research assistant, to the porter, to the cleaner in the department. Here you see a screenshot of one of the early routine instructions that we shared through Workplace at Facebook. At that time, COVID-19 didn't have its name yet. And the image on the left shows our division chair sharing a video message at very early stages of the, in Singapore's, just days after Singapore's first case over Chinese New Year. So this was trying to get people up to speed about what's going on and what was being done. Of course, currency of infection control practices was important because we had the experience with SARS. Practically the whole department was already N95 mask fitted, but it was still important to get everyone up to speed about good mask practices, both surgical and N95, and we had to do PAPR refresher training. So these images here and here show PAPR refresher training ongoing. And we had to put up online videos to just remind people about the many steps to safely put on and take off PPE. Peer reinforcement and was also important. Walking around, just modeling how to actually wash your hands, how to take off your mask, how to have a drink while having a mask on. These were all important practices which we needed to reinforce and make it second nature. The next area was creating hybrid working teams. So at Singapore General Hospital, our radiology department has subspecialty teams. So it's the neuroradiology, musculoskeletal, body imaging. So these teams would typically operate together in a homogeneous team. So because of the outbreak, we formed 3 hybrid teams that comprised of all the different subspecialties. So at least neuro, radiology, body imaging, musculoskeletal we represented. And these 3 teams would not cross over. So the image here you see is actually the team that is stationed at the inpatient center, and it has representatives from all the major subspecialties in our hospital. For hyper-specialized services, such as neuro intervention that had very limited numbers, they function as a separate independent group. So we basically segregated our people into different teams and we tried to make each team as comprehensive as possible. And finally, in terms of people, emotions have to be managed during an outbreak. I mean, there is a lot of uncertainty, there can be fear, there can be, on the other hand, indifference. And it was important to address the whole spectrum. So because, again, of our SARS experience, we early on had people share how their personal experiences during SARS, the importance of PPE and how to get through the anxious moments. There was also a lot of effort that we continue to put in to build team spirit and maintain morale. On the image here on the left, you see care packs are being prepared by our admin staff to be distributed to all the workers, all the colleagues, so that everyone gets a little encouragement amidst this pandemic. Moving on to places and equipment, PPE certainly is a major consideration. We initially had a decentralized distribution, but we subsequently centralized it to make sure that we could track our PPE resources better. Here you see an image of our mass distribution point, and it's important that whatever distribution areas you have allow for good safe distancing and also hand hygiene. You notice the hand sanitizers there when people collect their PPE. Since SARS, our department has had negative pressure scan rooms for almost all modalities. Here you see our negative pressure inpatient CT scanner room. So when we scan our high-risk patients, we would cover all the high-touch areas with plastic, even door handles and LCD screens, of course, the table. And we work with dedicated protocols for patient transfer, which I'll talk a bit more about later. The image here on the bottom left shows a new additional CT, which we loaned from a vendor to augment the CT capacity because, as Charlene alluded to, there's an extended downtime to properly terminal clean CT scanners. And this actually just came in about 2 days ago to our department. So portable imaging is the key workhorse during the pandemic for us. So we do portable where possible. Here you see portable radiography in action. These are our radiographers in the isolation ward in full PPE with the portable X-ray machines, and they're going in through to scan to do an X-ray on a real case here. And this is going through an anti room or intermediate room before they enter the actual patient's room. And the radiographers work in pairs, one as a contact radiographer who touches the patient and a non-contact or a clean radiographer who actually doesn't touch the patient. We've also had to push portable X-ray capability to multiple locations, the staff clinic, even to a new fever screening area, which was reconfigured from a car park. And here you see a container that we recently deployed earlier this week to house an additional portable X-ray unit for our screening location. Portable sonography is also an important problem solver. Here again, you see the staff in PPE and with the machines being wrapped up. The image on the bottom is moments before we actually did ultrasound on our first portable ultrasound on a positive COVID-19 case. So for ultrasound, we have a consultant-to-consultant discussion on the scan so that we can target it to minimize exposure time. And a pair, sonographer radiologist pair, goes up to do the scan together so that we can truncate the examination once the clinical question is answered. In terms of places as well, access control is an important consideration. Early on in the outbreak, we had access control at our department entrances. So this image here shows a staff member administering questionnaires, looking for symptoms, travel, contact history, before allowing a patient to come into our department. But this was subsequently shifted to a hospital level. So this other image here shows thermal fever scanner, and this is also where they would do a screening questionnaire for anyone who enters, but this time not at the department level, but at the building level within the hospital. This is for sustainability. So we keep a log of all visitors. We also discourage other doctors from other departments to come in. We do electronic rounds and meetings. And finally, we have decentralized working areas, which I alluded to earlier. So we have inpatient, a team at the inpatient, a team at the outpatient, and another team that's sort of scattered across various locations across the campus, which forms our third team. And they all join in remotely via video conferencing for meetings. And this collage here shows them participating in a department teaching session from their various workstations and various locations. The third domain is processes and policies. So in summary, every existing workflow had to be thought through with a COVID-19 lens, right? Think through everything that we do. How does COVID-19 affect it? One area which we realized we almost overlooked was our off-site imaging facilities. So we have some off-site scanners and other locations which you had to make sure had the same screening and infection control capabilities and standards as us. And here's an example of a clinical round being performed through a webcast. So teleconferencing, lone radiologist alone in a conference room speaking to the clinicians via laptop. And education was also taught, performed in the same manner. So imaging of the high risk or isolation cases. So we really talked about a consultant-to-consultant discussion to make sure that the scan is indicated. So the image on the top left shows us scanning a CT for the first time we did a positive COVID case some weeks back. So you can see people in PPE, the machine is prepared. We had to do a rehearsal before this. The patient was intubated. People just had to be sure how to come down. We have traffic control, dedicated lifts so that the patients do not crisscross with other people who may be inadvertently walking along the corridor. The scanning is done with full PPE. We do an on-table review of the images to make sure that they're adequate before we send the patient off so that we do not have to recall or do additional phases. And the wipe down and terminal cleaning is the one that takes a fair amount of time. So in addition to the wiping down and calling environmental services to clean the room, there's also UVC, and the image here on the right shows the UVC devices being deployed in the room to provide additional terminal cleaning. Our colleagues in anesthesia have also written up in detail about what they do in terminal cleaning and preparation for processes which mirrors what we do, and they published in the Canadian Journal of Anesthesia. This is also free access if you're interested. For interventional radiology, I won't talk much about it because there's already been a webinar on this, which is also the recording available on the CRS website. And my colleagues in intervention have also been instrumental in helping to prepare a checklist, which has been promulgated through the CRC website, which you also can refer to for interventional considerations. So for processes and policies, one additional area which we needed to make sure we put effort into was getting good rapid radiology reports out to the clinicians. So early on, this is a screenshot of our radiology information system. So we incorporated radio buttons so that radiographers could indicate if it was a COVID suspect confirmed or screening case. This was before COVID-19 had its official name, so it's been changed now. But by them selecting this, it would push the studies into dedicated work lists, which had enhanced manning to make sure that the reports were churned out faster, so that our clinical colleagues would get the radiological input in a timely manner. And finally, daily routine instructions had to be put out. Here's a meeting of our Red Science Disease Outbreak Task Force. This is actually taken later on where people are very spaced out, there's safe distancing, and many are participating through an electronic means. But we meet twice a day. We have a short morning huddle and a late afternoon meeting. And our job is to make sense of the hospital instructions, manage information overload. We have to translate all the information, all the instructions into bite-sized pieces that are relevant to the radiology staff so that they can handle the amount of information. And of course, we have to plan forward in terms of manpower, resources, and anticipate problems on a daily basis. So looking ahead, I think one of our main challenges will be sustainability. There's a lot of effort going into managing the processes, PPE. So we have to identify work stressors and weak points and mitigate these, right? We've got to make sure our staff are protected from infection and to limit any infection that may occur. And of course, we have to reinforce people will get tired working under such extreme conditions. And we have to make sure that they don't have any lapses or have address any fatigue. The other thing we are preparing for is surge demand. So we are actively reserving capacity for surge in cases. We're deferring non-urgent or elective cases. And we are also preparing for workforce depletion because we have to have contingencies where a staff member or whole team gets infected or quarantined, or if our staff get redeployed to areas of need like the emergency department, other clinical areas, or even the screening areas. So this is my last slide. I think overcoming COVID-19 has often been referred to as a marathon, not a sprint. So far in week 11, I feel like it's definitely a marathon with intermittent sprints because we're ramping up every now and then and there's really no break. So this is going to be a challenge for all of us, and I hope that what we've shared will be helpful, and I look forward to hearing from the rest. Before I end, may I please acknowledge that none of what I've presented would have been possible without the immense effort and sacrifices of my colleagues in the Division of Radiological Sciences and in our hospital as well. Thank you for your attention.
Thank you, Lionel, for a wonderful talk. Again, for those who have just joined us, there will be a Q&A, question and answer session at the end. You can start asking questions through the Q&A button at the bottom of the screen, and we will answer the question at the end of the session. It leaves me great pleasure to introduce the next speaker. Is Dr. Yang Hwan Kim, who is the chairman of the Department of Radiology from the Daegu Catholic University Medical Center in South Korea. As all of you know, Daegu was the epicenter for COVID-19 in Korea. And I think they have done a great job in controlling the outbreak there. So, Dr. Kim, please share your experience with us.
Okay, thank you. Can you hear me? Can you hear me?
Yes, we can.
Yes, okay, yeah. Can you see my slide?
You have to share your screen first.
Yes, I have shared my screen. So can you see my slide?
Can you share again?
Okay, I will share again.
Yeah, now we can see.
Yeah. Okay, can you see my slide?
Yes, very good.
Okay, thank you, Dr. Tay. I'd like to introduce briefly current situation of COVID-19 pneumonia in South Korea. Approximately 10,000 persons have been infected with novel coronavirus in South Korea so far. So as you can see, Daegu is hotspot in South Korea, occupying nearly 70% of total confirmed cases in South Korea. Because there was an explosive outbreak of COVID-19 pneumonia in the early February and in the end of February and early March, because mass infection in a specific religious sector named Shincheonji Church in Daegu City. So at that time, we had been tracking all confirmed patients by isolating high-risk group and conducting intensive COVID tests. So as a result, so with this effort, the number of newly confirmed cases dramatically down, like this graph, and the curve of total confirmed case in Daegu City is getting plateau, which means virus exposure has been controlled in Daegu City. Let me talk about how did we take care of confirmed patient in Daegu City. Paradigm was changed according to the period. In the early period of COVID-19, the number of confirmed cases was small. So through the intensive epidemiologic survey, all contacted took a COVID test and the high-risk group was isolated, and all confirmed COVID patients were hospitalized. However, in the period of explosive outbreak of COVID-19, we couldn't conduct intensive epidemiologic survey due to extensive community spread. So at that time, there was a shortage of medical facilities because all confirmed patients were hospitalized without classification of disease severity. So we couldn't accommodate all patients. So at that time, many patients should wait at home before admit to a hospital. So some urgent patient visited the ER, and some patient died at the arrival of ER. So we were so embarrassed and scared because we didn't know who was infected and who was not infected. So there was a frequent temporary shutdown of ER and the CT room. So many healthcare workers were in quarantine. Therefore, emergent medical system was nearly collapsed in Daegu City. So local government and the local medical association decided to change the paradigm from prevention of COVID-19 to decrease mortality by directing medical resources to patients with severe cases of COVID-19, and also announce public advice for living rules such as wearing mask and keep social distancing. Government established the patient managing task forces to classify patient by disease severity into mild, moderate, severe, critical. Patient classified as moderate and above immediately transferred for in-hospital treatment. Patient with mild COVID-19 infection transferred to regional public relief hospital or living treatment center. So PRH and the LTC have been set up starting in Daegu City. So as a result, COVID outbreak has been stabilized in Daegu City. So next, let me talk about how radiology department deal with COVID-19 pneumonia in Daegu Catholic Medical Center. We divide actually inpatient control and outpatient control. Actually, there are 3 admission routes for COVID-positive patient to the tertiary hospital. One is outpatient COVID-19 screening clinic, and another is a transfer from public relief hospital or living treatment center, and the other is emergency center. Emergency center is the most dangerous hotspot where can be easily exposed by virus. So it means ER is the most important place to prevent intra-hospital virus transmission. So we have to strictly control ER to prevent virus transmission in hospital, as well as to protect our colleagues. So actually we divided into ER zone into 4 sectors: outdoor COVID screening clinic, clean zone, contaminated zone, and negative pressure isolation room. So this picture shows the outdoor COVID screening clinic just in front of ER. So all patients visiting ER should take a COVID screening test like this, including body temperature check and history taking about acute respiratory symptom, and contact history with the confirmed patient, and the travel history of foreign countries, and the visit history of specific church in Daegu. And if no risk, is it emergent? If no, transfer to outpatient clinic. But if yes, transfer to clean zone in ER. If patient has high risk factors, is it emergent? If no, conduct a COVID-19 test and the X-ray in the outdoor COVID screening clinic like this. And recommend to stay at home. And if test is positive, transfer to outpatient clinic. If test is positive, admit to COVID ward. So if patient with high risk factors and emergent condition, transfer to contaminated zone in ER and conduct COVID-19 test, as well as appropriate emergent treatment. And if test negative, move to clean zone. Test positive, move to negative pressure isolation room in ER, and then admit to COVID ward. So this is the contaminated zone ER. So you can see exclusive portable X-ray in contaminated zone and negative pressure equipment. All rooms in contaminated zone are completely separated from each other to prevent cross transmission in contaminated zone. And this is clean zone. The entrance of clean zone is different from the entrance of contaminated zone to prevent cross transmission, and all rooms are open in clean zone in order to monitor by medical team. This is negative pressure isolation room. So if a patient is confirmed by COVID in ER, transfer to this isolation room and stay in this room until COVID ward is available to admit. This is COVID ward. COVID ward is completely separate from outsiders, and all confirmed COVID patients should admit the COVID ward in the evening in order to avoid contact with the general inpatient person, outpatient person, as well as healthcare workers. So we take a daily simple chest X-ray follow-up and the CT scan on admission day and on discharge day. Radiographer working at COVID ward should wear level D PPE like this slide. And we allocated exclusive CT room for COVID-19. So radiographer working at COVID CT room should wear modified PPE. So actually we developed modified PPE consisting of readily available equipment because we don't have enough level D PPE. Modified PPE consists of N95, KF94 mask approved by KFDA, and the surgical hat, and the face shield, disposable gown, and the gloves and the shoe covers. Confirmed COVID patient should be carried in negative pressure cart like this, and the healthcare workers with the patient transport service should wear level D PPE like this, and the patient should be transferred along a designated route in the night time in COVID world, because we would like to avoid to contact with other persons. However, anytime from contamination in ER. Actually, enhanced CT scan is not necessary in confirmed COVID patient to evaluate the disease severity. So non-enhanced CT scan should be performed under patient inside the negative pressure room in confirmed COVID patient or suspected COVID patient from ER in order to avoid the virus exposure in the exclusive CT room. So enhanced CT scan is quite dangerous. There is a high risk of virus exposure in COVID CT room. So enhanced CT scan is not necessary. Take a non-enhanced CT scan under patient inside the negative pressure bag, and then clean the CT table 3 times with the disinfectant. If enhanced CT scan necessary, we have to open the negative pressure bag. So is it emergent? If no, take a CT scan after result of COVID test. If test is negative, take a CT scan in routine room. If test positive, close CT room and the sterilization and reopen 2 hours. If it is emergent, take a chest HL CT scan in addition to enhance the other part of CT scan to evaluate COVID pneumonia, because the diagnostic accuracy of chest CT scan is quite high. So if chest CT scan shows highly suggestive of COVID pneumonia, close the CT room and the sterilization and reopen 2 hours later. If HL-CT scan is negative, just clean the table 3 times with the disinfectant. If COVID CT room is exposed to virus, immediately close the CT room and sterilize the CT room. Healthcare workers should wear PPE like this and turn off negative pressure equipment, and then sterilize the room with disinfectant and wait for 30 minutes for dry. And then turn on the negative pressure equipment, and we can reopen in 1 hour later. So let me talk about operating guideline for IR room. Is interventional procedure necessary in IR room in suspected COVID patient from contamination in ER? If no, consider bedside procedure. If it is necessary in IR room, is it emergent? If no, delay schedule after result of COVID test. If COVID test negative, do the procedure wearing modified PPE and just clean the angio table 3 times with disinfectant. And if COVID test positive, do procedure wearing level D PPE and then close IR room and the sterilization and reopen next day. If it is emergent, take a chest HL-CT scan to evaluate COVID pneumonia. If HL-CT scan shows highly suggestive of COVID pneumonia, do procedure wearing level D PPE and then close IR room. And if HL-CT is negative, do procedure just wearing modified PPE and clean the angio table 3 times with disinfectant. Sterilization technique is almost the same to CT room, except reopen next day. What about outpatient control? All persons coming into hospital should have active screening at the entry of hospital like this. If patient has high risk factor, recommend to stay home and transport to outpatient. The patient enter the hospital can visit IR, outpatient clinic, and diagnostic radiology. This is outpatient COVID screening clinic. So I'd like to skip this slide because of time limitation. So in conclusion, a total of 115 patients with COVID-19 pneumonia have been hospitalized so far in our hospital. A total of 16 persons, including 10 healthcare workers, and 6 patients have been infected with novel coronavirus in our hospital so far. Among them, only 2 patients and 2 residents are associated with cross transmission in hospital. And with appropriate strategy, nowadays all healthcare workers have been released from quarantine and be able to get back to hospital. Thank you for your attention.
Is it okay now?
Yep.
Sorry, there was some transient drop in signal. Yeah, I was just saying thanks to Dr. Kim. Dr. Kim himself is also an interventional radiologist. There are not many of them in Daegu, so he has been very, very busy. Okay, for those of you who just joined us, there will be a Q&A session at the end. You can submit your question by clicking on the Q&A button. For the Singaporeans participants, there is one CME point for this session. So if you stay till the end, we will capture your attendance and we'll submit your name for the CME point. Okay, now it gives me great pleasure again to introduce our last speaker, Dr. Johnny Ma from Hong Kong. Johnny is the Chief of Service of Radiology at the Princess Margaret Hospital. And if I understand correctly, it is Hong Kong's designated infectious disease hospital. So as I mentioned earlier, Hong Kong is one of the few countries in the world that has really managed to control the COVID-19 situation very well, despite its close proximity with mainland China. So Johnny, please share with us your experience.
Hello, can you hear me, Kian Hong?
Yes, we can hear you very well.
Okay. Thank you, Kian Hong, for your kind introduction. So today I'm going to share with you our department's strategy and experience in response to COVID-19 infection in Hong Kong. So just some background information. Our department has 4 hospitals in Hong Kong, Kowloon West cluster, namely the Caritas Medical Center, the Yan Chai Hospital, North Lantau Hospital, and Princess Margaret Hospital. And actually, as you know, Princess Margaret Hospital is the designated infectious disease center in Hong Kong since 1975. And actually, during the SARS outbreak in 2003, there were over 1,700 confirmed cases in Hong Kong. And we actually had treated about 1/3 of the cases in our hospital. And interestingly, there were a very high rate of healthcare workers getting infected. Around 300, over 300 of the healthcare professionals got infected in Hong Kong, and some of them died. So we really had a very painful experience in the SARS outbreak. And the lesson we learned from that outbreak is that there are 2 main areas that we need to pay attention. One is isolation, and the second is PPE, which is very important. As you know, during the SARS outbreak, we are not very sure about the etiology and also the method of transmission of the virus. So actually at that time, we were very having limited knowledge, and we didn't have the adequate PPE for the protection of the staff. So with that, the government has funded the establishment of a new infectious disease center in our hospital, which was opened in 2007. And this is a separate ID block, which is equipped with the high standard of the infectious control and isolation facilities, with negative pressure isolation wards, including some ICU beds and some OT as well. And there are also a level 3 biosafety laboratory for handling highly contagious specimens. And we have also radiology facilities there. And you can see in the ID block, we have the CT scan and the general radiography and the C-arm and also the ultrasound facilities. All these are in the negative pressure rooms to prevent the spread of the infection. And coming back to the current infection in Hong Kong, as you know, the outbreak started in Wuhan in December last year. And the first case in Hong Kong was an imported case from China in late January, during the Lunar New Year holidays. And the second case was also an important case, but it's a resident of Hong Kong traveling back from Wuhan. So the first 20 cases of the first confirmed 20 cases will be treated in our hospital, and the rest will be distributed in the other hospitals in Hong Kong. So with that, we in our department, we plan to have implement some strategies to contain the virus and also come back with the infection outbreak. And our department actually sets 4 main strategies in response to the outbreak. The first thing is infection control in terms of the containing the infection, prevent cross-infection, and also staff infection. And the second strategy is to enhance the service capacity and also ensure the sustainability of service, because we know we have to put the resource in treating, in imaging resource, in monitoring, in the diagnosis of the COVID-19 infection. But at the same time, we need to maintain the essential diagnostic and interventional radiology service, especially the acute service, emergency service, trauma service, and oncology service. So we have to make sure we have the capacity to deal with these different services. And the first strategy is to engage our staff and provide training as well as boost their morale. And the fourth strategy is to have enhanced communication with different stakeholders, including our own staff, hospital infection control team, hospital management, clinicians, and other radiology departments in Hong Kong for knowledge updates and appropriate and timely response. So the first strategy is, of course, is the most important, is infection control. So the basic principles of infection control, we have to contain the infection, we have to segregate clean and dirty zones, we have to control and remove the contaminants through, for example, disinfection and vigorous hand washing, and also minimize cross-physical contacts. So in PMH, we are actually very lucky because we have a separate and isolated block of infectious disease center. So we keep all the confirmed and suspected cases in PMH in the isolation ward in IDC. So in IDC, we have the necessary CT scan, ultrasound, fluoroscopy, and general imaging facilities to do the imaging without transporting the patient and spreading the infection. And how about the main department or the other hospital in our department without isolated infectious center? So we have to do the routine infection control measures. For example, screen a patient at the department entrance or hospital entrance. And also we set up specific gang up and gang down areas in the procedure rooms. And we group the CT cases together and allocate downtime for room disinfection and for at least 30 minutes and allow passive air exchange between the cases. And in other hospitals, we don't, with only one CT scanner, we will designate the suspect or confirmed case to the last time slot of the day, usually around 4 o'clock in the afternoon. And we also try to do portable X-ray instead of transporting the patient to our department or around the hospital to reduce the patient transport and reduce the chance of infection. And we also try to reduce the physical contact time between the patients and our staff, and also enhance the patient flow. For example, in A&E department, we ask our physicians to avoid unnecessary X-ray other than the chest radiograph in the fever room, so as to avoid long contacts with our staff and facilitate better and faster patient flow. And also for those confirmed cases, if the CT, for example, a scan of the body is required, for example, in the case of biliary obstruction, suspect biliary obstruction, we will ask the clinician not to ultrasound, we do a CT scan instead, so as not to prolong the contact time between the operator and the patient. And for suspected cases awaiting PCR result, we try to defer the appointment until the result is available. So concerning the service capacity and sustainability, we try to modify our service. We have the service reduction plan. We cut the outpatient elective service, including CT scan, ultrasound, mammogram, and nuclear medicine cases. And we ask our radiologists to screen the request form. And then for those cases which are suitable for rescheduling, we ask our clerical staff to call the patient to defer the appointments. And we also, in this way, we have a better infection control. In that, there's less patient congregation, and we can also redistribute our manpower to other more prioritized areas. For example, we deploy manpower to reporting of inpatient and urgent X-ray, CT scan, and also perform more interventional radiology to speed up the patient discharge. And we also suspend more high-risk procedures, for example, burial enema and modified barium swallow. And in CMC, we segregate the team of radiographers into clean and dirty teams, with the dirty team led by experienced radiographers who have experience during the SARS outbreak in 2003. And we also suspend all the face-to-face clinical radiology meeting and replace them with video conferencing, email, and phone discussion. This is one of the online clinical radiology meeting with our orthopedic surgeons. This is our specialists, and this is our trainee. So in this way, we can maintain our service without having the direct contact with the physicians. So the third area is about the staff. We have to engage our staff, boost the morale, and provide training to them. So we have to provide infection control training. We encourage our staff to attend the updates of seminars in infection control. We also have drills for gang up, gang down. And of course, we try to advocate social distancing, hand washing, these kind of measures in infection control. And these are the posters we put up in the exam room just to remind ourselves and our staff to have a vigorous hand washing and hand hygiene. And these are the posters in the procedure rooms and IR rooms concerning the gang up and gang down procedures, step by step, just to remind ourselves and also our staff to have the proper procedure of gang up and gang down in infection control. So we also have the, because we are a training center under the regulation of the Hong Kong College of Radiologists, so we have to maintain the quality of training. And although we cancel the face-to-face clinical and educational meeting, we substitute these meetings with email case discussion and also phone discussion and video conferencing, as well as e-presentations. And in this area, we also have tried to encourage our staff to engage in some academic output in terms of paper publication and some of the also knowledge sharing. So concerning PPE, which is quite a tight supply globally, we have to ensure the availability of PPE. So we communicate with our hospital infection control team for the supply of PPE. And in the past, we are actually quite liberal in the usage of surgical masks and N95, as we put all these masks in the exam room. But we found there may be wastage, so we start rationing and also regulation on the usage of these masks. We give every staff 2 surgical masks every day, and also N95 on demand. And we also explore the possibility of procurement from outside source as well. And because we have different hospitals in our department, we try to redistribute the resource of the stock of the PPE in accordance with the supply in different hospitals. And this is the proposed guideline of the Hospital Authority Coordinating Committee in Radiology. And we can see each area of the radiology department, they have different recommendations for the recommended PPE. And we can see that actually most of the areas in the department, surgical masks are already sufficient for protection. But in some areas or some scenarios, we have to better to put on N95. For example, for plain X-ray taking in the A&E in airborne isolation room, and also in portable X-ray in ID ward, and during disconnection with the ventilators in CT scan or MRI, And during GA, in IR procedures GA, during intubation, and also during CPR, there's recommendation for putting on N95. And otherwise, surgical mask will be sufficient in most of the cases. And we also encourage academic output, and our staff is involved in some of the publications overseas and also locally in the medical journals. And concerning the staff morale, we try to get a set of target collaboratively with our staff. For example, we emphasize the safety as more important than efficiency of throughput, because overworking with our staff will create mistakes which will aggravate safety, aggravate infection. There will be difficulty in infection control if there's overworking. And we also try to listen to the feedback of our staff. And as you know, the procedure time of each exam will be prolonged. So we kept the case booking in every section to about only 3 or 4 cases in each section, just to allow time for disinfection and air exchange between the examination. And we also have to facilitate the application of special rental allowance and special emergency response allowance by the hospital authority for those working in high-risk zone work, who are mainly radiographers and also healthcare assistants, because they, for example, in the A&E area, which is regarded as high-risk zone area, they are eligible for special rental allowance, which they allow them to rent a hotel or a room so as to segregate themselves from the family members. So we try to facilitate their application in these areas. And finally, communication is very important. As I say, with different stakeholders, we try to have good communication with our own staff and also outside stakeholders. For example, we ask our ID team physicians for judicious imaging requests, and only those indicated requests will be entertained. And we ask the clinicians to book CT instead of ultrasound for cases in order to have less physical contact with the radiologists or radiographers and shorter exam time. And we also avoid duplication and ask our ID team not to request a chest X-ray on the same day with the CT scan, as to reduce the physical contact between the radiographer and the patients. And we also try to establish a system of sharing of information effectively, intradepartmentally with emails and WhatsApp, and also interdepartmentally with the emails and WhatsApp and messaging application apps. And we also share our presentation with the other hospitals, because we are the first hospital in Hong Kong to have treating these patients. So we make an e-presentation to share with other hospital authority, radiology staff, so as a way of knowledge sharing and updating their knowledge on the radiology findings of COVID-19 pneumonia. So the current situation in Hong Kong, in our hospital, we have already admitted 90 cases of COVID-19. And right now, we have done around 74 CT scans. Most of them are HRCT of the thorax, and we have performed over 700 portable X-rays. Most of them are chest X-ray, and some of them are abdominal X-ray, KUB, and X-ray of the extremities. And right now, we are having many of the cases treated in other hospitals in Hong Kong, around 500 cases in different hospitals in Hong Kong. And this is the update curve, epidemiology curve in Hong Kong. You can see actually we are now having around 900 cases. And we have the first wave here, which is rather flat, and then the second wave here. And most of them are imported cases from Europe. And hopefully we don't have the third case again, third wave again. And so this is my last slide. You can see there's actually in Hong Kong and in many parts of the world, there's a coronavirus pandemic shopping with the tissue paper, tissue rolls, and rice, oil, etc. So I think with the strategies I've mentioned concerning the infection control, service modification, staff engagement and training, and also enhanced communication, we try to transform ourselves from the fear zone or panic zone into the learning zone and growth zone, and try to contain the virus eventually. Thank you very much.
Thank you, Johnny. That's for the amazing talk. Okay, we'll go into the Q&A session now. We have several questions and limited time, so I'm having a hard time trying to choose what questions to ask. I think one of the questions that I have been appear quite a few times is what is the percentage of COVID-19 patients that require a CT scan? Maybe we start with Charlene. In your hospital, how many CT scans are performed for COVID-19 patients?
Okay, so in our experience, obviously our experience will be different locally compared to other countries, but in our experience, when I encountered the first 2 CT scans that I showed today, I recall that we had about 7 patients admitted at the time. So doing a bit of rough math, that actually is about about 2 or 1 to 2 in 7. So we're talking about a range of about 15 to 20%, which I think happens to coincide with the percentage of patients who present with in the severe phase of infection. And actually, I do believe that we will actually encounter different rates of CT utilization as the epidemiology of this disease actually progresses. So early in I believe it will be a J-shaped curve. So early in the onset of the epidemic, we did not know very much about the disease. And so I think there was a lower threshold to doing CT scanning. And I think now where we are kind of more comfortable with treating patients and we have a more set workflow, we tend to image a bit less. However, if we do reach a situation, unfortunate situation, if we become saturated, like other countries which have, topped a few thousand cases and their hospitals are overwhelmed, I do expect to see the rate of utilization of CT pick up again. So I do believe it will follow the epidemiology of the disease and it's not going to be a fixed utilization rate.
Okay. Dr. Kim, what about the Daegu experience? How frequent is CT scan performed for COVID patient?
Yeah, in our hospital, we perform CT scan in all COVID inpatient.
Oh, all
yes, all of COVID inpatient.
What is the reason for doing that?
So the reason why we perform all of COVID inpatient, because sometimes simple X-ray is absolutely normal, even though chest CT scan shows ground glass opacity. So that's the reason why we always perform CT scan, especially inpatient COVID.
Do you have experience where the PCR swab was negative 2 times and CT scan show changes? Do you consider that as positive patient or you would still require the PCR test to be positive?
I don't know exactly, but I think PCR is more important to diagnose COVID than CT scan because there is a similar finding to COVID pneumonia in other diseases such as eosinophil pneumonia or alveolar hemorrhage. So actually, I experienced 1 case of COVID negative patient. So COVID PCR test was 2 times negative, but chest CT scan shows peripheral ground opacity. So we suggested COVID pneumonia in this patient, but test was negative 2 times and finally confirmed COVID negative and confirmed as alveolar hemorrhage. So, and also a PCR kit, the accuracy of PCR kit in Korea quite high. So that's why we believe PCR more than just the CT scan.
Okay, the next question is for Dr. Lionel Cheng. How important is social distancing and how do you actually execute or carry out the social distancing?
Well, For social distancing or safe distancing or physical distancing, I think it's just one of the measures that we have to put in place with everything else in the context of good PPE, good hand hygiene, and segregation and stuff, and other infection control mechanisms. But social distancing or safe distancing is just making sure people don't come too close together, at least 1 or 2 meters apart in a deliberate manner. I just give an example, one of the weak areas that we find is during breaks or meal times where people have to take out their mask and they have to congregate, and being humans, we like to talk to each other and go closer to share stories. So we had to, for example, deliberately break apart space out the tables and chairs in our pantry areas and create new dining areas for people to sit effectively alone and spaced out from each other. We've even had markings on the floors in the places where our staff would buy food so that they would not stand or queue too close to each other. So it's a mindset change, and the management also has to facilitate it with moving physical infrastructure like furniture around or putting reminders on the ground so that even if one person does get infected, the amount of people he or she spreads it to is limited, and the workforce does not get significantly compromised.
Thanks for that. The next question is for Dr. Ma, Johnny. You showed that you have done portable chest X-ray, a lot of it. So as we know, the portable films sometimes is quite difficult to interpret. Do you have any tips to how to do a good portable film so that you don't miss those subtle ground glass changes and so on?
I think portable X-ray has certain limitations, especially the quality of images and the resolution as well. And actually in our center, we have done quite a number of chest portable X-ray, but most of the time, we are not reporting these radiograph by radiologists. They just interpret the film by the clinicians. So we don't have very much experience on the reporting of the X-ray. We just concentrate more on CT scan. As we know, a certain proportion of the patients, their chest radiograph actually quite negative. So in the case of suspicion or we try to assess the severity of the disease, usually the ID physicians will go ahead with the CT scan, and we will sometimes, and many a times actually, we have encountered those negative X-ray, we have positive HRCT findings. And for those chest radiograph, actually it's a bit difficult because of the peripheral nature of the ground glass opacity, which is sometimes mimicked by the soft tissue, overlying soft tissue, which can be quite mimicked. So it's actually quite difficult to differentiate.
So what proportion of your COVID patients have a CT scan done?
In a hospital, actually, I think around 80 or 90% of those cases perform CT scan. And you have seen we have around 100 admissions for those COVID-19 patients, but we have around 70 or 80 cases of HRCT. So maybe around 80% of the cases got the HRCT. And the indications mostly they try to monitor the disease progress, and also sometimes the chest X-ray is rather equivocal. So they try to be certain whether there's any pneumonia, because many of the patients, they just have upper respiratory tract symptoms. They are negative on HRCT. So this is a way to differentiate the upper tract and lower tract infection, and also to monitor the disease progress.
Thank you. The next question is for Dr. Kim. In your slides, you show an interesting negative pressure bag when you transport the patient.
Yes.
And for non-contrast scan, actually, you don't take the patient out of the bag. You just scan the patient.
Yes.
So is this bag commercially available, or is only special in Korea? You can't find it?
I think it is commercial available in Korea, but I don't know, is it available in outside of Korea? So we actually bought 10 negative pressure bag for treatment of COVID pneumonia nowadays.
Right. Another follow-up question to earlier on. You mentioned you do 100% of CT scan for 100% of the COVID patient. So
Yeah.
what proportion of patients where you have positive CT findings but negative normal chest X-ray?
I don't know exactly. In our hospital, most of COVID patients have more than moderate symptoms or signs of COVID. So actually, normal chest X-ray is quite low because of moderate or severe COVID disease. So I think some patient showing a negative chest, maybe less than 10%, and among them, approximately, I'm not sure, maybe 50% of normal chest X-ray revealed a positive finding on CT scan, such as subtle ground glass opacity.
Okay, looks like there's a lot of interest in CT scan. The next question, back to Johnny again. So you mentioned you've done quite a bit of CT scan, and from your talk and from Linus' talk, we know that the disinfection procedure can be very time consuming. So realistically, how many CT scan can you do in your center a day in a COVID patient?
That's a very good question, because initially we actually try to perform more, and we schedule 6 or 7 or even 8 cases in a section. But we have feedback from our radiographers that it's really impractical to do so many scanning in a single section, because we have downtime and also disinfection time and patient transfer time. So, and now we only perform around 3 to 4 cases in each section. So maybe around 1 hour for 1 patient. So one day maybe around 8 or 9 patients.
Okay, that's good. Okay, you mentioned, Johnny, this question for you also. You mentioned earlier in your slides that you have, because of the SARS experience, it have helped you with the COVID-19. So what proportion of your staff in the department have experienced SARS, and did they, or do you think, did they make a difference in the whole approach in your hospital's handling of the COVID-19 outbreak?
Yeah, it's 2003, so it's already 15 or 17 years old. So only a small proportion of our staff, including myself, is have experience of SARS. Actually, maybe around 10% of the staff having this experience. So for radiographers, they are a few of them are very, very experienced, so they can lead the team of radiographers, because most of the radiographers are rather young, so they are quite sort of worried and even a bit panic because of the uncertainty, also of the history of the severity of the previous SARS and the mortality. And so I think these experienced staff are really very helpful in terms of sharing the experience in the previous SARS, especially the adequacy of PPE, which is very important, very, very important. So you can see currently in Hong Kong, we don't have a hospital staff getting infected from the cross-infection from the patients. So I think PPE is very important.
Okay, I think I'll just do one last question. This is directed to both Dr. Kim and Dr. Ma as well. There's a question about negative pressure interventional room. Are your interventional room negative pressure? And if they are not, do you need to close the room, after the procedure for longer to, to let, I guess, things air out a bit? Maybe we start with Dr. Kim.
Yes, actually, our interventional room doesn't have negative pressure equipment. Only exclusive CT, COVID CT room has negative pressure equipment. I think according to infection control team in our hospital, they recommend at least more than 3 hours close IR room, maximally 1 day. It's enough to sterilize environment of IR room, even though negative pressure equipment is not here. Okay.
Okay, Johnny, what about you?
Okay, in our hospital, in the ID block, we have the negative pressure rooms, and we have the C-arm there. So for non-vascular intervention or very simple vascular intervention, we can do the intervention in the negative pressure ID block rooms. But for maybe for more sophisticated procedures, for example, GI bleeding, which needs a dedicated DSA, we have to transfer the patient to the main department IR suite, which is not negative pressure. So for this, we have to observe more strictly the infection control measures, just like in the case of TB for droplets and airborne caution. So we'll put the case as last case of the slot, maybe the last case of the day. So we evacuate all the other patients and all the passageway. And after performing the procedure, we'll leave the room empty for whole night. And we have a complete disinfection of the room. So I think that's the way we tackle with these patients.
Thank you very much. Okay, I think time is up. I would like to close the session, and I again like to thank our 4 distinguished speakers. Very informative. I think we have learned a lot from Daegu and Hong Kong. Our college website, there's a COVID-19 resource page, and inside there we have publications on imaging findings, how you reconfigure departments, and so on. And the webinar recording will be posted there as well. So yeah, so I think I will just end the session here. Thank you very much and good night.